Interpreting an arterial blood gas can feel like decoding a foreign language, especially when you are in the middle of a busy clinical round. Welcome back to my ClinicalMedEd channel. I'm Dr. Raza, and today we are diving into an ABG Mini-Masterclass. I'm breaking down my proven 5-step approach to help you master the acid-base balance with absolute confidence. We'll apply this framework to 2 real-world clinical scenarios, taking you from the raw numbers to a definitive diagnosis. This is the foundation for our upcoming deep dive full masterclass on ABGs. So let's get the basics right. The 5 components of an arterial blood gas: pH is to look at the acid-base balance, PaCO₂ is to look at the ventilatory status, bicarbonate for the metabolic status, predominantly from renal perspectives, PaO₂ and SaO₂ are the partial pressure and the oxygen saturations, and base excess is to look at the overall acid-base reserve in the body. Clinical indications to do an ABG: obviously whenever you are worried about the respiratory drive or the ventilatory drive, so whenever there is oxygenation or CO2 problems, altered mental status due to hypoxia, hypercapnia, when you are worried about the acid-base status due to any reasons, DKA, sepsis, etc., in ventilated patients, and also when you want to titrate oxygen therapy. Otherwise, the VBG is good enough, but if you are worried about oxygenation in COPD, then ABG is the gold standard. Normal reference values: millimeter mercury is used all over for CO2 and O2. However, kilopascals are used in some-countries, so you can just use your own reference ranges. Normal pH is 7.4 plus minus 0.05, so anything 7.35 to 7.45. CO2 is 35 to 45 millimeters of mercury, oxygen 80 to 100 millimeters, and bicarb 22 to 26. In some reference ranges 22 to 28, saturation is above 95. And base excess, I always say consider 0 and plus minus 2, so 2 either way of 0. The 4 basic acid-base disorders: first of all, metabolic. So metabolic acidosis, anything which drops the pH, and bicarbonate, which is a buffer, bicarbonate buffer, and the basic buffer, if that's low, that's a primary metabolic acidosis. In carbon dioxide, if it's low, that's an acidic gas. That means there is a compensatory response. So examples of the metabolic acidosis: DKA, lactic acidosis, renal failure. Remember all those MUDPILES. Respiratory acidosis, once again pH will be low, which indicates acidosis, and the partial pressure of CO2 will be high because it's an acidic gas, so hence it will corroborate by going higher, which means there is respiratory acidosis. The compensation obviously from bicarb, which is a buffer, will be opposite. So bicarb will be raised because again in acidosis the body is trying to compensate for it. Examples include COPD, sedation, any neuromuscular disorders. Metabolic alkalosis, pH will be above 7.45, hence alkalosis. The bicarb will be quite high. Again, it's a metabolic component, so you would expect for the primary metabolic alkalosis for the bicarb to be high. And CO2 is an acidic gas, so it should be low it should be high because it's trying to compensate by increasing the acidic component in the blood. So the common examples include severe vomiting and diuretics, and also hyperaldosteronism. Finally, respiratory alkalosis, again pH will be high, above 7.45, because it's respiratory, so we would expect the respiratory component to corroborate with the change in the pH. So if the change is alkalosis, the acidic gas should be blown off by the body, hence the CO2 will be low, PaCO₂ will be low, which would indicate primary respiratory alkalosis. The compensation in terms of the acidic component or the buffer component to counter the alkalosis would be to reduce the bicarb, so that the acidic component is compensating for this alkalosis. So hence the bicarbonate will be low. Examples include hyperventilation in terms of anxiety, pulmonary embolism because you're trying to compensate for hypoxia, high altitude, and early sepsis. This is the key slide: 5-step ABG method. First of all, step number 1, look at the pH. Is it acidaemia or alkalaemia, acidosis or alkalosis? If it's less than 7.35, it's acidosis or acidemia. Above 7.45, it's alkalaemia. Within that, it's normal. So remember, normal pH still does not exclude that there is no acid-base disorder. Step number 2, once you establish the pH, look at the primary disorder. Is it respiratory or metabolic? So CO2 is an acidic gas, so any corresponding change of CO2 will be, if it corroborates with the change in pH, that will indicate primary respiratory disorder. And if it's bicarbonate, which is a buffer, alkaline, if the change in bicarb corresponds to the change in pH, then it's a primary metabolic disorder. Step number 3, after establishing primary disorder, look at the compensation. And we'll come to the Winter's formula for metabolic acidosis, because in metabolic acidosis you need the CO2 adjustment, and the CO2 has to be blown off for compensation. And remember, the units should be in millimeters of mercury for the Winter's rule to apply. Step number 4, if there is acidosis, metabolic acidosis, you need to establish the anion gap, which is sodium and minus the addition of chloride and bicarbonate. In some centers, sodium plus potassium minus the sum of chloride and bicarbonate, but potassium doesn't contribute that much to the cations. Normal range 10 plus minus 2. Remember, base excess I said 0 plus minus 2, so here 10 plus minus 2, which means 8 to 12. High anion gap, think of the MUDPILES mnemonic. Step number 5, oxygenation, should be 80 to 100 millimeters of mercury. You can calculate the alveolar arterial gradient, which is AA gradient, and which is partial pressure in alveoli minus partial pressure in arterial system. Normal should be less than 15. Steps number 1 and 2. Step 1, assess the pH. Is it normal, 7.35 to 4.5? Is it low, which indicates pH of less than 7.35, which is acidemia? Is it high, above 7.45? That indicates alkalaemia. Acidosis is the process of generating acid. Acidemia is the presence of acid in the blood, emia. That is what we measure. So although it's a misnomer, acidosis and acidemia are usually clinically used interchangeably, but this is the technical difference. I'll cover probably an ABG Masterclass in detail at some point, but this is a quick version of this concept. Step number 2. Once you have established that, let's say, pH is less than 7.35 and it's acidosis, you look at the CO2. CO2 is acidic gas. If the CO2 is above 45, above the normal range, and obviously it's an acidic gas and the pH is low, hence you can safely say that it's a primary respiratory acidosis. Now, if you look at the pH and if it's above 7.45, which means it's alkalosis, and if you look at the pH and if the pH is low, which means the acidic gas is being blown off by the body through hyperventilation, and the alkalaemia is now corresponding to the blowing off of the CO2, that means it's a primary respiratory alkalosis. So remember, this PaCO₂ moves with the change in the pH in primary respiratory disorder. Coming to the metabolic component, let's say there is acidosis. When you look at the pH and if it's less than 7.35 and you want to see whether it's metabolic or not, you look at the bicarb. Bicarb is a base, it's a buffer. And if the base or the buffer is low, which means the disorder, the acidosis, is due to primary metabolic disorder. So it's a primary metabolic acidosis. If there is alkalosis, that means there's more buffer, more base in the body, and the bicarb is also high, then the alkalosis is due to primary metabolic alkalosis. So remember, bicarb moves with pH change. If the bicarb moves with pH change, it's a primary metabolic disorder. Unlike the CO2, if the CO2 moves with the pH change, that's a primary respiratory disorder. So that's a really, really crucial point. Once you have established the acid-base disorder and whether it's primary respiratory or metabolic, then you need to look at the compensation. So step number 3 and 4. So predominantly step 3, looking at the compensation. Really, really, really important component. I cannot overemphasize. Number 1, do not worry about the compensation formulas in the middle. You will have medical calculators, MD Calc, up to date, MBOSS, or just go to Google and you will find all those. So just remember the concept. First of all, metabolic acidosis. Once you have established it's metabolic, you need to establish the CO2, which is an acidic gas. So you need to check whether the CO2 is expected to do what it needs to do, which means in normal phase, the CO2 should be blown off by the body to compensate for the metabolic acidosis. Now, the formula is PaCO₂, and it should be in millimeters mercury, remember, not kilopascals. PaCO₂ equals 1.5 times bicarbonate concentration, whatever the product of this number, or whatever the product of these two, you add an 8 to it, and then whatever number plus minus 2 of that digit should be the expected compensation for the CO2. This is the Winter's formula. Now, if the compensation falls within this range, it's appropriate response. However, if the CO2 number is higher than this number, this means you've got a respiratory acidosis on top of metabolic acidosis. If this number is below the expected number, then you can say that it's a respiratory alkalosis in addition to metabolic acidosis. So really crucial exam question for USMLE, MRCP, OSCEs, Arab Board, FCPS in Pakistan, all of them to understand the concept. So don't worry about the formula, Google it or use calculators, but remember the concept please. Next, metabolic alkalosis. The formula is, this is not Winters. Winters is only metabolic acidosis. For alkalosis, you expect the compensation of CO2, which is an acidic gas, should be 0.7 times bicarb. This number plus 21 plus minus 2 range. So if the final number falls within this range, it's an expected compensation, which is appropriate. However, if the CaO2 is opposite, the final number is opposite to this, let's say if the number is lower, then you can expect respiratory alkalosis on top of metabolic alkalosis. However, if the number is higher, then you can expect respiratory acidosis in addition to metabolic alkalosis. So this means a mismatch would indicate a secondary respiratory disorder. Really, really crucial. Respiratory acidosis, especially if it's acute, the change in bicarb should be like increase in bicarb, which is a buffer, by 1 milli equivalent per liter for every 10 millimeter rise in CO2. If it corresponds to this change, it's expected compensation. If the change is higher than this number, which means the basic buffer is higher, then you can expect metabolic alkalosis with that. If the change is lower than this, then you can expect a metabolic acidosis in addition to respiratory acidosis. So which means if there's a mismatch, it's a secondary metabolic disorder. For chronic respiratory acidosis, the formula is, obviously you need higher compensation in chronic phase because of the time availability. So the change in bicarb of it should be 3.5 milliequivalents, like roughly 3 to 4. So average is 3.5 milliequivalents for every 10 millimeter rise in CO2. Now, if this is the figure matches this is expected compensation. So it means it's pure chronic respiratory acidosis. However, if there's a mismatch, then you've got a secondary metabolic disorder in addition to the primary chronic respiratory acidosis, which means if the bicarb number, if this final number is higher than the expected number, then you can expect a metabolic alkalosis in addition to chronic respiratory acidosis. If the bicarb is lower, which means a basic component, the buffer component is lower, hence is acidosis, you can expect chronic metabolic acidosis in addition to chronic respiratory acidosis. So remember the expected compensation and the mismatch. For respiratory alkalosis, you have two numbers, 2 and 5 milliequivalents for acute and chronic respiratory alkalosis for bicarb. So once you have established that it's respiratory alkalosis, look at the bicarb, which is the opposing mechanism or the counter-regulatory renal mechanism. So the drop in bicarb for every 10 millimeter drop in CO2 should be 2 milliequivalents per liter in acute respiratory alkalosis and 5 milliequivalents in chronic respiratory alkalosis. So this number or these two numbers, if they fall within this range, then it's an expected compensation. The disorder is primarily respiratory alkalosis without any secondary metabolic disorder. However, if the numbers fall out of this range, then it's a secondary metabolic disorder, which is a mismatch. What does it mean? That if the drop in bicarb is more than this expected range, which means now there is more acid in the body, then it's metabolic acidosis in addition to respiratory alkalosis. However, if the drop in bicarb is not higher than this number, which means there is more bicarbonate than expected, then it's a metabolic alkalosis in addition to respiratory alkalosis. So then it's a mismatch. Step number 4, once you have metabolic acidosis, calculate the anion gap. The simple formula is the difference between the sodium and the sum of chloride and bicarbonate. Sometimes you can use sodium plus potassium, but potassium does not contribute that much. Normal reading, normal value, as I said, is 10 plus minus 2 milliequivalents per liter, so 8 to 12. High anion gap causes MUDPILES, mnemonic, and normal anion gap is like diarrhea, renal tubular acidosis. Step 5, oxygenation. Number one, check the partial pressure of oxygen on room air. Normal should be 80 to 100 millimeters of mercury, which is calculated on the blood gas. Hypoxemia, if it's less than 80, it's indicative of hypoxemia. Then once it is confirmed, then you look at the alveolar arterial gradient with this formula, which is PaO₂. So that is the alveolar oxygen is equal to FiO2 into 713. This number minus the result of PaCO₂, which is on your blood gas, divided by 0.8. Remember, both PaO₂ and CO2 should be in millimeters of mercury. And then once we have this alveolar oxygen number PaO₂, then you calculate the AA gradient by subtracting the PA, the alveolar oxygen, from arterial oxygen. Normal number should be less than 10 to 15. Now, causes of high alveolar arterial gradient will be anything which leads to mismatch between the oxygenation in the alveoli and the blood supply. So oxygenation could be pulmonary embolism, the blood supply problems could be pulmonary embolism or shunt, and the alveolar problems could be consolidation or lung collapse, atelectasis, etc. A very quick reference guide. First of all, if the pH is low, it's indicative of acidemia. If the carbon dioxide PaCO₂ is high, it indicates respiratory acidosis in case of a low pH. If the bicarbonate is low with a low pH, that indicates metabolic acidosis. If the anion gap is above 12, that is high anion gap metabolic acidosis, HAGMA or MUDPILES mnemonic that we discussed. If the compensation is matched, then it's a pure metabolic acidosis without a mixed mixture. And if the PaO₂ is less than 80 millimeters of mercury, it is indicative of hypoxemia, which should be treated. Quickly, two clinical scenarios. First one, a 22-year-old woman with type 1 diabetes presents with 2-day history of nausea, vomiting, abdominal pain. She has not taken insulin for 3 days. Exam reveals tachycardia at 118, borderline normotensive 98/60, tachypneic at 28 with Kussmaul's breathing, fruity breath odor, and clinically dehydrated. The blood gas is right in front of you. So take a moment to have a look at it, and then you can see the 3 red boxes means these are abnormal numbers. So pH is 7.18, CO2 22, bicarb 8, oxygenation is 98, sodium and chloride are in front of you. So you can pause the video here and then consider the questions. What is the acid-base disorder? Is the compensation appropriate using Winter's rule? And then calculate the anion gap number 3. And fourth is what is the diagnosis? So if you can pause, and then we'll come to the discussion on the next slide. Answer to step 1, scenario 1. Let's calculate together. What is the pH? 7.18, so it confirms acidemia. Let's look at whether it's primary metabolic or not. So bicarb is low 8, so that confirms that it is metabolic acidosis because it's not high CO2, which would have been respiratory acidosis. Once we have the confirmation of metabolic acidosis, then we said the next step would be to look at the compensation. The formula is written at the bottom if you see. So you want the expected PaCO₂ to be equal to 1.5 times the concentration of bicarb, which is 8 in this case. So 1.5 times 8 is 12 plus 8, so that is 20. So 20 plus minus 2 would be the actual compensation, which in this case it is appropriate. So this means it's a pure disorder, not a mixed disorder. So there is no respiratory component to this. So it's a pure metabolic acidosis. Now looking at the anion gap calculation, the formula is sodium minus the sum of chloride and bicarb. So sodium was 138 minus chloride and bicarb. Chloride is 102, bicarb is 8, so that gives us 110. The difference of 138 and 110 is 28, so it's above the normal range. So again, anion gap, we said 10 plus minus 2, so 8 to 12 would be the normal range, so it's almost 3 times. So that's 28. So it's high anion gap, HAGMA, metabolic acidosis. And step 5, oxygen saturation is 98, which is normal. Again, that could also indicate tachypnea. The patient was tachypneic, so it may be spuriously high saturations. Anyhow, so the causes of HAGMA, we discussed about the MUDPILES, and remember, so anything which is contributing to extra anion, so diabetic ketoacidosis in this situation. Key management principles, the most important one is fluids, aggressive IV hydration, insulin administration as soon as possible, bolus plus maintenance according to the body weight, correction of electrolytes, especially potassium, because potassium, giving insulin will drive potassium intracellularly. So that is really crucial. And then frequent monitoring of everything. So glucose, potassium, anion gap, and ketones. And finally, also looking at the underlying precipitant. Is it non-compliance to medications? Is it infection? Is it dehydration? Is it vomiting, viral infections, etc.? And the second scenario, a 68-year-old man with severe COPD on home oxygen, LTOT, 2 liters per minute via nasal cannula, presents with a 4-day history of worsening dyspnea and pyrrhus sputum. He is drowsy, using accessory muscles, tachypneic at 32, saturation is 82% on home oxygen. Chest X-ray shows hyperinflation with right lower lobe infiltrate. Blood gas results on inspired oxygen of 2 liters nasal. pH 7.28, CO2 72, bicarb 33, O2 46, SATs 80% on inspired oxygen of 28%. Questions? What is the primary disorder? Is this acute or chronic? Why is the bicarb elevated in this case? What is the immediate management priority? Take a moment. You can pause the video and answers on the next slide. Discussion for case 2. Let's work it out together. So what's the pH? 7.28. It's confirmed acidemia. Is it primary, respiratory, or metabolic? Let's look at the CO2. So carbon dioxide is high in this case, which means it's a primary respiratory acidosis. Now, is it acute or not? If you look at the formula at the bottom, for acute respiratory acidosis, the change in bicarb would be 1 milliequivalent higher for every 10 millimeter higher than the baseline CO2. So CO2 baseline, if it's 40, in this case we have a CO2 of 72, so you're talking about 32, so 32 would be 3.2, so 24 plus 3.2 is 27. So in this case the bicarb is 33, the actual calculated bicarb is 33, so it means it's a chronic compensation. Okay, so it's not acute. Now let's look at the chronic check. Now expected bicarb in chronic, if you look at the lower diagram, the respiratory acidosis chronic, you would expect a 3.5 milliequivalent per liter change for every 10 millimeters rise in CO2. So here the differential was from 40 to 72 of CO2, which is 3.2. And the rise of bicarb should be 3.5 times the change in the differential of CO2. So 3.5 into 3.2 is roughly 11.2. So 11.2 plus 24 is 35. So the expected bicarb in chronic type 2 respiratory failure should have been 35. In our situation, the bicarb is 33, which again, what it means, because of the respiratory acidosis, the bicarb has dropped slightly, which is an attempted compensation by the metabolic system for the respiratory acidosis. So again, this is an appropriate acute and chronic type 2 respiratory failure. Oxygenation step 5 is obviously 46, very low, so it's severe hypoxemia. So what is the diagnosis? Acute and chronic respiratory failure, respiratory acidosis due to type 1 respiratory and also type 1 respiratory failure because of the PaO₂ being low, and it's likely due to the acute exacerbation of COPD. How do we manage this scenario? Obviously, it's acute exacerbation of COPD leading to both acute and chronic type 2 respiratory failure plus type 1 respiratory failure. So it's a mixed disorder. So titrated controlled oxygen of the target stats of 88 to 92%, although it's controversial with current evidence. However, let's stick to the basic gold standard evidence at the moment. Non-invasive ventilation, assisted ventilation for hypercapnic failure would be appropriate in this case. Bronchodilators, so short-acting beta agonist and muscarinic agonist will be helpful. Salbutamol, ipratropium. Systemic corticosteroids, IV or oral, although oral is equally good as long as the patient is not vomiting and does not have any absorption problems. Antibiotics if infective exacerbation. Antivirals if there's a confirmed evidence of a viral infection like COVID or influenza. And if everything fails, like especially an IV, then might need intubation or ventilation if patients ceiling of care is determined to be to be appropriate for level 3 escalation. So here we are with the final take-home messages. Number 1, use a systematic approach like a 5-step approach. As we said, look at the pH. Step 2, primary disorder, is it respiratory or metabolic? Number 3, look at the compensation. Number 4, if it's metabolic acidosis, look at the anion gap and think of the causes. And finally, oxygenation. Pearl number 2, a normal pH, as we discussed before, does not exclude an acid-base disorder, because if it's a mixed disorder, then it can cancel out an effect on pH will not be obvious. Pearl number 3, compensation is never complete. If pH normalizes, suspect a mixed disorder. It links with point number 2. Pearl number 4, always calculate the anion gap in metabolic acidosis and use MUDPILES for high anion gap acidosis HAGMA, and you can use used carbs or hard ups, any of those two mnemonics, for normal anion gap acidosis or NAGMA. Point number 5 in COPD, keep titrated oxygen saturations of 88 to 92%, although evidence is currently changing, but follow the local evidence or the most recent evidence as the case may be. Elevated bicarb in COPD indicates chronic compensation, but not primarily metabolic alkalosis. So remember, a high bicarb in a patient with COPD is a chronic compensatory mechanism, not like a metabolic alkalosis. And again, calculation for compensation with all those formulas will be helpful. And finally, arterial blood gas in itself is not in isolation. It has to be taken in context, the whole clinical context of the patient, of history, examination, and rest of the investigation. So I really hope you like this module. So please post your questions, comments, subscribe to the channel, and hopefully I'll come up with a detailed acid-base balanced masterclass, including the theoretical concepts and everything in detail at some point down the line. So stay tuned.